practitioners elsewhere on the chain refer back to the GP. The role of the GP, and if there aren't GPs around, the primary healthcare nurse in a primary healthcare clinic is critical to the success of clinical care in the primary healthcare setting. We also want to move towards outcomes objective, where we're not just measuring numbers. We don't want to just know how many patients you've got on your books and how many of them are diabetics. We want to know how many diabetic complications were prevented because compliance improved, and that part of the country that you are looking after is no longer referring so many, and that the complications are not as severe as they used to be, et cetera, et cetera. Then we are looking at outcomes, and we will strengthen the health system in that way. So the gatekeeping role is critical, and it's linked to the referral responsibility. Okay, so how do you get accredited to be a provider and paid for by the fund? The first thing is that you have to be registered. So we heard last week or this week of 18 practitioners who are illegally practicing. In fact, one of them is practicing as a pulmonologist in Ekurhuleni and is not registered anywhere as anything, and has never been trained and has no medical degree. So that obviously is dangerous for the public. And so the first obligation is to be registered with the professional council and stay registered. And the NHI, through that registry I showed you just now called the provider registry, will automatically detect whether you are currently accredited, currently registered with a professional council. And this is not just for doctors, for every professional who has to register with any professional council. Once you're registered and remain registered, doing your CPD points and whatever else is required, you then need to have your practice certified. Even if you're a one-person show or if you're a group practice, the practice needs to be certified as compliant with the basic set of standards by the Office of Health Standards Compliance. At the moment, we don't have separate GP standards. A process was started in 2017, but it didn't conclude, and there are discussions about getting that going again. But we know that getting regulations for separate standards may take a while. So right now, the Department of Health is in discussion with the Office of Health Standards Compliance to use parts of the general standards, so the standards for its health establishments, as a starting point, and only to measure the ones that are relevant to general practices. And we would use those until such time as there's capacity in the Office of Health Standards Compliance to do the necessary consultations and get a specific GP standard. We also know that the legislation for Office of Health Standards Compliance says that every practice or establishment needs to be recertified every 4 years, but there's nothing so far in the regulations that says it has to be a physical inspection, and the Office of Health Standards Compliance is looking how to best use their meager resources to make sure that they are able to certify. And some of that may end up being self-assessment with a sort of random 10% being checked by the office or whatever. But I mean, I don't want to preempt how they may go about doing their certification. So once you are firmly registered and certified, the practice can then apply to the fund to be accredited. And the implication of being accredited is you're allowed to claim from the fund, and the fund will pay you. So instead of having to claim from 74 medical schemes or however many of those currently pay you, you would be linked automatically once you sign your contract and are accredited. You would be linked automatically to the system. And every time you register a patient's consultation and what you've done, it'll chalk it up, and it will monitor what services you are providing. But let me step back a bit. For hospitals, they will be reporting on DRGs, and there may be other ways that they are reporting, and there may be some limited fee for service as well, and they will be paid per service that they provide. For primary healthcare, it won't be like that. It will be through a risk-adjusted capitation to a geographical area, which will be quite big. There are likely to be somewhere around 250 to 260 contracting units for primary healthcare. I'll come to that in a minute. And the fund will then contract, or you will pay providers through that contracting unit, and they will be responsible for integrating all the practitioners into a comprehensive service within that let's call it a sub-district geographical area. I'm sure there are going to be questions. I won't try to explain the details of that right now. So, but accreditation will require that a practice delivers a minimum range of personal healthcare services. And that you will be registered, that if you try and claim something outside of what the fund has accredited you for, the system will flag it and say you're not accredited to deliver the service. So if you suddenly start doing, I don't know, cesarean sections, and you're not supposed to be doing obstetrics because you didn't apply to be accredited for it, the system will pick it up and say, what's going on here? And then they may pick up, oh, you're an assistant in somebody else's surgery, and that's fine, and then they'll authorize. So however that will be, it will be the minimum range of services will be registered for in your accreditation certificate. You have to have the appropriate mix and number of healthcare professionals to deliver that range of services. So that may be that if you are including a multidisciplinary practice, which is obviously where we want to go, you can't offer a fully comprehensive multidisciplinary care spectrum and be accredited for it if you can't show that the healthcare professionals are in that team. Even if they're not in the same building or the same geographical space, if they're not in the team, then obviously that's going to be a problem. The third point that the bill says is that to be accredited, the practitioners or the providers must adhere to the treatment protocols and guidelines, including the prescribing of medicines and the procuring of the health products from the formulary. And lots of people don't like this, but this is pretty much the global standard. Anywhere you go around the world, health services, except for in America, the health services tend to have pretty clear protocols and guidelines that apply across the health system. And then the formulary is big enough to respond to that set of protocols and guidelines. The fourth one I've already mentioned, you need to agree to adhere to the referral pathways. And obviously we need to be explaining what that means and put regulations and guidelines in place to make sure that everybody understands what it means before you agree to do it. And the last one is that your system has to be, your IT system must be compatible with the national normative standards for interoperability. And there will be certain items in your data which need to be available real time on the system so that the NHI can monitor which patients are getting care and which aren't. And we can see if a patient is hopping from one practitioner to another, or if illegal people are using the same ID number as a bona fide person at the same time on the same day in another practice, et cetera, et cetera. So there are all kinds of checks and balances in our fraud and corruption that need to be dealt with through the information system. You will not be required to purchase a prescribed patient information system, but there will be guidelines of what must be in the system, and the language and software of that system. We will, from early next year, provide a laboratory where practitioners and other service providers can take their software and have them assessed so that you can see whether they are indeed compatible or not with the normative standards. Okay, so the million-dollar question for you in a primary healthcare environment is, what is a contracting unit for primary healthcare? Because I've said that the bill says that the money is going to be given on a capitation basis to a contracting unit for primary healthcare. So the bill just gives an enabling environment. It does not spell it out in detail. And we need to work out the details of this. And as Prof. Mash said, this is where you're going to get an opportunity to work with us and tell us that it's very different in Northern Limpopo compared with Joburg, Sandton, compared with the Kalahari. And there are different ways in which we are going to have to apply the same framework so that we do get proper contracting units for primary healthcare. But the essence is that these units will be where we manage the provision of primary healthcare, including prevention, promotion, curative, rehabilitative, ambulatory, not rehabilitative in-care, and home-based care and community care within a demarcated geographical area. And the government will demarcate the geographical areas to be roughly around a primary, let me not use the word primary, around a district hospital. There may be more than one district hospital, but the areas will be around an accessible district hospital to which patients can be referred for first stage hospital care. And this is the preferred organizational unit for primary healthcare services. The bill does not say it's exclusive, so it anticipates that there may be exceptions, which we'll have to design around. Okay, so that's what's intended with the contracting unit. There are lots of complications, lots of issues we haven't solved yet. And as I say, we'll be experimenting a bit with this in proof of concepts in the months and in the year to come, and you'll get an opportunity to interact with us on that. Briefly on remuneration of practices and providers. How are we going to calculate remuneration? Who's remunerated? Who's employing the doctors? What happens if I don't get paid? These things that obviously bother you. Okay, so the remuneration model is, as I said, an outcomes-based capitation model is what we would aim for. It's risk-adjusted, which means that the population that has more morbidity and more complications in that morbidity would be weighted, the individuals in that population would be weighted more heavily. So children, women of childbearing age, and the elderly in the first instance, but then there may be more complicated factors in the formula allocating this risk adjustment. And then we would like to have, but it may have to come at a later stage, an outcomes-based adjustment. And I've sort of indicated, for instance, if you manage to have less strokes, less diabetes referrals, less this, less that, because the primary healthcare system's working, you should be rewarded for that. Okay, so clearly defining the scope of the services is important. It's absolutely essential. And ideally, healthcare contracts should pay for outcomes, not outputs, and not just on numbers. But sometimes it's necessary to have outcomes and outputs in the same formula. But we were striving for this quality framework you can see below. I'm leaving it at a high level deliberately. Okay, so the practitioner fits in the team around a patient. And sometimes there are all kinds of complications for a patient. It might be that patient may have more psychiatric care, more this, more that. If you're male, you don't have obstetric care, but you have something else. But all these practitioners are important in a comprehensive care environment for a patient. We know all of this. How do we do it in practice? We move systematically towards multidisciplinary practices, which may be relatively easy in an urban environment, but are going to be very difficult in most of our rural environments. So we have to do it in stages and not be rigid in that process. Okay, so who's going to pay and who's going to employ? Last night I was asked this, no, Sunday night, I was asked the question, aren't we all just going to be employed by the National Health Insurance Fund? The answer is no. The National Health Insurance Fund's got to look after the finances and the money. And the National Department of Health and the provincial departments of health do not want to be involved in employing people. The private practices, and there are lots of reasons people like to be in private practice. So private practices might be an individual, self-employed, or a group of people self-employed who work together, and there's no reason to change that. There are sometimes managed care organizations and more structured environments. Sometimes people like to be in a non-government environment. So those are all private practices. They're not government employees. But there are people who work inside primary healthcare environments in the government system, either at clinics or community health centers and so forth. And that's also fine. The NHI fund will pay the cup. How are we going to pay and how they're going to have a bank balance and who they're going to be and how they're going to distribute the money are all matters that are in our think tank at the moment and are not prescribed. But the cup will be responsible for distributing to the accredited providers within that geographical area. And that's what's open for us to experiment with going forward. As far as health products are concerned, once you are accredited, so take one step back. The fund is going to have an Office of Health Products Procurement. That will not be buying anything. It will be procuring. And if we look at the definition of procuring, this is the high-level stuff where the fund will work out how many billion or million or hundreds of million tablets of or whatever other health products are going to be required for a given period. And the fund will then go and negotiate the prices. And through various committee structures which are prescribed in the bill and will be presumably become part of the Act, the prices will be set and the providers will be set. Then all accredited providers of healthcare will be told, these are the suppliers who have complied and these are the prices. And you can then buy from them at those prices, provided you're accredited. If you're not accredited, you will pay whatever they want to charge you. Okay, and those medicines and other equipment and other products will be in the formulary, which you will see from time to time, and you'll be able to get off your membership with or your accreditation link to the NHI. You'll be able to see it on the website. Okay, so I think that I've said enough about health products. As far as laboratory and imaging is concerned, we learned during COVID this is a little bit more complicated, and we may need to, for some laboratory and imaging services, we may need to not include them in the DRGs or in the package and have fee for service. But we're looking at what that means, and as I say, we learned some of this during COVID. So let me stop there rather than take questions. Maybe I've just made more questions than answers. Thanks.
Thank you. Thanks, Nicholas. Yes, you've certainly stimulated a lot of questions. I think we've got about half an hour to address as many as we can. What I'm going to do is I see there's certain people have asked multiple questions. So I'm going to start off with Untitled. If you want to unmute yourself, but can you just ask one of your questions, not all of them? And then I'll come back to you later if we can. Yeah, so go for it.
Good afternoon, Prof. Good afternoon, Dr. Crisp.
Hi there.
On the issue of risk-adjusted capitation, two things came to mind. You get what is called gamma regression when you do your risk adjustment, or you use the linear model. Now, I just wanted to find out which one did you guys go for?
Okay, so at this stage, we haven't gone for anyone. We have got a 3-phase approach that we are still discussing, keeping it very simple in the beginning. We've been advised by other countries, begin very simple, and then introduce other factors once your data improves. So we have not made a decision on anything yet. It's still in the pot, and if you want to influence that discussion, you're very welcome to engage with us on that.
Great, thanks. Shabir Musa, you want to ask one of your questions?
Thanks, Bob, and thanks, Nicholas, for being part of this discussion. Can I ask, will GPs, what do you expect GPs to be paid as providers by the CUP? What is the mechanism of payment that you're expecting that to happen? So in a way, what is the GP expecting come future? Will he be enrolling patients and then be paid per capita, or are they fee for service, or is it, just to clarify that? Because the CUP gets the money by capitation, but you don't say the GP gets it.
Yeah.
And so if I may just clarify that as well, will any GP be able to contract, or will it be a selection by the CUP saying, oh, okay, we'll only choose these because the public service doesn't need any more GPs? And so it's a very selective approach with GPs.
Okay, so thanks, Shabir. The principles are down on paper, but the details are not down on paper. So the principles are that there's no mechanism prescribed for excluding anybody. So if there are 6 GPs all working on top of one another or 60 working on top of one another, there's nothing that says the state can be selective. If all 60 or all 6 apply to be accredited, they can be accredited. But the amount of money that's going to be available to pay for the patients they're looking after is going to be set by the number of people that are in the area that they are looking after. I mean, that's what capitation means. And even if it's slightly higher, weighted for argument's sake in phase 1 to children, women of childbearing age and the elderly, which is how we're advised to go about it in the beginning, it means there's just less to share amongst the many. And over time, what that means is that some practices just become unviable. Hopefully by shifting patients out of specialist care back into the general practice environment in primary healthcare, there are more patients that are being seen, but it will still be that some parts of the country are oversupplied. I mean, we know this. This is one of the objectives of NHI, is to get better equity. And so a young practitioner who thought when he went to university that he's going to practice, I don't know, in Houghton, may now find that that's a very occupied space, and may find it more attractive to go and work somewhere in Sedibeng or somewhere where there's a less crammed environment. So the actual amounts that people get paid and that actual formula is still wide open for discussion. It's not, I mean, obviously there's thinking around it, but there are as many thoughts about how to do it as there are people in a room every time. So once again, you're welcome to engage and suggest how it should be done, but the aim is over time, and I stress the over time because one doesn't just today halve a budget in one district and shift it all to another district. But the inequities are so huge that there will be shifting of funds taking place over time, and that's going to affect where practitioners practice. I'm not sure if I've answered your question.
No, I think you have. It may have generated yet more questions, but I'm going to move on to Amanda. You want to ask your question? So Amanda's question was, I don't know if she's still here. I have been refused permission as a GP to form a group practice with a family physician by the HPCSA and the Council for Medical Schemes. Would be nice to get this changed now, long before NHI. So this is a big problem, actually, I think, around the country.
Yeah.
And of course, also, I can tack onto this question, how are you going to pay specialists in family medicine who are working often entirely in the primary healthcare space? How will that work? Yeah.
Okay, so first of all, the Department of Health and particularly the people who've been working on the NHI agree 100% with what Amanda said there, and we also want to do it now. And in fact, we're not the only ones who said so. The Health Market Inquiry said that these are antiquated and outdated regulations in the HPCSA, and I now have regular meetings with the Council for Medical Schemes, and we are agreed that this is not how things are supposed to work. And so we are all in the same space. It means undoing some regulations, and it means convincing some people who think differently. And it's not going to happen overnight, but we are certainly moving in that direction. The NHI and primary healthcare in the new reformed health system require that we allow group practices. And when we talk about group practices, we're not even just talking amongst doctors. We're talking about why can't you be in practice with a physio and a speech and hearing therapist and whoever else, and how those practices are structured should not be rigid either. We should just encourage that people are able to offer multidisciplinary care to patients and their families, and we need to work out how to do that. We're not the first country thinking about this, and so we can learn from what others have done. The question about specialists. Look, the difficult one is the family medicine specialist, yourselves, because you are exclusively in the same space as a GP who only has a MBCHB. So I have a personal view on this. I have a master's degree in medicine. It took me 5 years to get that degree after my MBCHB. I worked really hard to get it, but I get paid exactly the same as a GP if I go into private practice or if I were in clinical practice. It's only as a specialist in public health I might be able to charge more. And even then in the public sector, those posts are so few and far between. Unless I go into academia, there's no space for me. That's why I work as a consultant and I try and get a job here. So you have to find your way. And if things really don't work, we need to make suggestions on how to make them work. So whether there's a premium on the distribution by a cup to encourage the GPs to go and specialize and become family physicians, or even to get diplomas in various other clinical skills to up their game. Those are things that we need to have on the table going forward. But to write that into rigid regulations now would probably be extremely irresponsible. So again, these are things you have your your academy, and you should be putting your heads together and making formal submissions on how you see this happening.
Yeah, it sounds like we need to actually, because I think that's going to be a huge concern to people who, because you know, if you're a specialist in family medicine, it's a clinical speciality, you know, where you've trained clinically to offer services in the primary care space. You know, so I think there would be huge concern if that training is not in some way taken into account. And as you know, in the public sector right now, it's fully taken into account. So family physicians are employed on a specialist scale. And in the private sector, I mean, it should actually also be taken into account, and the medical schemes have lagged behind in doing that, although some are now doing it, such as Discovery. So I think that's going to be an issue going forward. Let's see, Johan just asked, well, it sounds like a simple question, but it's a big concern for people. How long after you give the service will you get paid?
Okay, so the quicker the money moves out of the NHI fund, the better for the fund, because it is there's less opportunity for fraud and corruption. There's nothing prescribed in the legislation as it stands at the moment, but the way in which money works in government is that Treasury makes tranches of payments to entities and government departments once a week. So for argument's sake, if you've got a total allocation that is coming your way as a public entity, which the NHI fund will be, 1/52nd of that money will arrive once a week in your bank account. And then you spend that money during the week. Now the NHI fund is set up that it doesn't buy any goods or services. It purchases healthcare on behalf of people. So it's not like a provincial government, which has to buy oxygen and medicines and this and that, and can stagger the payments to its various suppliers, let's call them. The NHI fund is set up that it has to pay to the providers of healthcare on contract. So the terms of the contract is what's important. And for some, the contract could be weekly. So for some, the contract could be weekly, and for others, the contract could be monthly. But it definitely would not be more than monthly. So, I mean, where the hospitals are paid monthly and primary practitioners are paid weekly or whatever, it's not, I don't think it would be feasible to do it on a daily basis, but certainly it should be on a weekly basis.
I suppose the way you describe it, a lot will depend on the managerial capacity or competence of the CUP, because that's actually what the money will come to them, but they're the ones who must distribute it.
Yes.
Yeah.
Yeah. So that's why the CUPs are a major part of our work for next year.
Yes. Zilla North, are you here still? You want to ask your question?
Hi, Bob. Thank you. Just a quick one. I probably don't understand it well, so I thought I'd just ask for the sake of somebody else. Will risk-adjusted capitation not result in a move away from basic prevention healthcare if we're aiming to treat the sickest?
Yeah, Zilla, no, it shouldn't do that at all. In fact, risk adjustment means that we are weighting the value of an individual in the community differently. So if you are a healthy young male and the predominance of that particular community is healthy young males, we know we spend less because there's less morbidity on healthy young males than there are on elderly people, for instance. So that the risk adjustment is on patients who, or people in the community. It's not on, yeah. So if you know that you need to do more intervention in a community, you need to allocate more money to do more intervention. But that doesn't mean that the output or the work that is done is only on curative. I've said already, if we are able to show our outcomes are reduction in an A, B, and C, because of the way that CUP pulls together and deals with children with hearing disabilities or diabetics who don't understand how to take their medicines and so forth, then collectively you get a better outcome. And that's what we're trying to achieve. So I'm not sure why it would lead away from basic preventive healthcare. No, not at all. It's included in the
That's
package.
awesome. That makes it a lot clearer. Thank you.
Okay.
Thanks. I think that this person's name is Vasi Naidu. You want to ask your question?
Okay, thanks, Prof. My question relates to medicines. I need to know, how will the state pay for the medicines? And will the medicines be only available from a pharmacy or from a doctor's room, or what method of medicine procurement we're looking at? And if the medicines are going to be obtained from a pharmacy, then what would be the way that would work? Will it be via the pharmacists using the procurement system or the tender system of the state? Or even if, for that matter, the doctor? Or would it be that you buy your own stock and then you just invoice the state for that? So I just want some clarity about medicine. I think it's a very important commodity in terms of patient care. And so that, and also, you know, there again, we talk about preventative medicines and curative. So if we can get some idea about that. Thank you.
Yeah, okay. No, great, thanks. So let's start at the central point. The objective is that anybody who's accredited and who needs to treat their patients and deliver the benefits that they have been accredited to provide. So if you're accredited as a practitioner to provide something that requires you to buy tetracyclines and oxytocin and a range of other stuff, you will buy those products at the price that is set by the Office of Health Products Procurement. And you can buy them from any of the suppliers who've been listed and endorsed by the NHI fund to deliver, provide those, and it's not just medicines, it's all health products. But the idea is, and again, these things happen slowly, to move away from centralized warehouses. Obviously, if a provider wants to centralize a warehouse, like the hospital groups or the provincial government might still choose to do, that's fine. But in a private setting, if it's better for you to procure those medicines and have them in your rooms, and more convenient to do that than to send your patients to a pharmacy every time, it depends how you include that pharmacist in your multidisciplinary team. So I think the number of solutions is many because the geography of our country is so diverse. I mean, if I think back to areas where I worked in Limpopo and still travel frequently there, and into rural areas of the Eastern Cape, the model that you're going to need there is very different even from a small town. And so we don't want to be too prescriptive. So in a small town, it might be, and I live in the Western Cape near a small town where it actually works quite well. The practice where I go for my GP care, there are three doctors in practice. There are 2 pharmacies in town, and the practice still keeps some medicines, but not everything. And they will refer patients, obviously write a script and send patients to get medicines if they are unable, if it's not the common things of the top 20 or whatever they're going to keep in the rooms. But in the future, instead of having to buy it in the open market, if that whole practice is working as a group practice and is accredited, then by accrediting, you sign that you will have access to the formulary and you will purchase off the formulary. It's good for everybody. It's just there are times when it's not really viable to have to send the patient every time to a pharmacy, but there are other times where it's just not viable for the practice to keep amounts of medicines that are more or less frequently prescribed, let's put it that way, or that the pharmacist might have to purposefully buy them for a particular patient or family. So I think that there are going to be several different solutions, but the idea is to push the prices down and make sure that everybody has access to medicines at the same price.
Thank you. That's very clear. Can I just have a follow-up questions, please?
Okay.
In terms of the multidisciplinary, now you know that certain acts actually prevent the doctors actually owning a pharmacy. Now, in a multidisciplinary practice, would you be paying the medicines to that practice and that practice can have doctors and pharmacists and optometrists and all the other healthcare professionals with it, and that practice gets paid, and then of course the money would be divided. So will that act that actually prevents that type of I won't call it a collusion, but prevent that type of an association, will that be thereafter be changed? Because it's in terms of some ownership regulations that a doctor or anybody, you know, cannot have an interest in a pharmacy. So will that be changed for the multidisciplinary practice that NHI is looking at?
Yeah, so there are lots of pieces of legislation that need to be changed, and they are so outdated, they must be changed. So we must create an environment that encourages multidisciplinary teams, not detracts from them. So you're absolutely right. And we needn't wait for years and years and years. The Health Market Inquiry already said that this is an iniquitous practice and it's very outdated. So even without the future of the NHI, it's something that we need to do. But there are not all practitioners and not all regulators will agree with you and with me. And we need to persuade them, and we need to make sure that the regulations do get changed, because it's not always acts. There are some pieces of legislation, and that's a longer process because it has to go to Parliament. But many of these are regulations or standard practices within professions. There are lots and lots of examples that need to be undone. But the principle is yes, where you are speaking about and where I am saying we need to go, that is where we are headed towards.
Okay, great. So now I think most people who asked the question have had a chance, but actually Untitled and Shabir were particularly prolific in their question writing. So I'm going to give them an opportunity to ask maybe one or two additional questions. Untitled, you want to go first?
All right, Prof. Dr. Crisp, on the issue of performance-based payment under capitation, have you considered it as an option? Because possibly specialist family physicians could actually use it as an incentive to actually make it valid to be part of private practice. So have you considered performance-based payments under capitation?
Yes, so indeed we have. So we call it value-based or outcome-based, performance-based. Yes, very definitely, and it's one of the things we want to test. We know that they have been tested in various private environments at the moment, and we've been party to some of those, let's call them projects that are going on around the country. And next year, we would like to take some of those into case studies and see exactly how they might work. And again, want to try them in different geographical settings. But yes, we definitely would like to look at that. One may not be able to start there because we don't want to overcomplicate the issue while we are putting systems in place, but there's always pioneers who are willing to try new things, and we should not be limited. So yes, the answer definitely.
Thanks. So I'm going to ask a question, and I'm going to give Shabir another chance as well. I mean, the way you described it, the service benefits are related primarily to conditions, and services related maybe to conditions. So in a way, in my mind, it's sort of almost like the outputs of primary health care. And so there are almost like two questions. I mean, interestingly, you said that the service benefits won't be the same everywhere. So I'm imagining what you meant is that there's a minimum package that must be there, and then there could be add-ons. But then I had the question about, so that defines, in a sense, the conditions and maybe the range of services related to those conditions. But where is the service delivery model defined? So now there were bits and pieces of that you mentioned, like the mix of providers and that kind of thing. But where, for example, would population health management, a population perspective, which is a very key part of our health system at the moment, or it's trying to be, where would that come into this whole certification and accreditation process? So I suppose I'm really asking, where do you sign up to the essential service delivery model components?
Yeah. Yeah, so I mean, obviously it's complicated, but what one wants is that for the CUP as a whole, the package of care that must be provided in that CUP is what we must define. But if we take a cup around, let's take Jane First Hospital in Sekhukhune, and we say, who are the providers who are going to deliver the same package as around Tembisa Hospital in the East Rand? The providers in each of those two areas who are available now, and if we take a third one and say Bishop's Court in Cape Town, they're going to be completely different. But we still have to provide that full package of care to that population. The structure of the providers and what happens in this one's rooms and the next one's rooms are going to be very, very different. I mean, I know that area around Sekhukhune, there might be 2 or 3 GPs. They all do sessions in the hospital. They run around doing lots of different jobs and so forth. There's likely to be no physiotherapists in private practice. There may be a pharmacist, and that's it. They're not going to be audiologists and physiotherapists and all the other kind of care that we need by way of multidisciplinary practice to reach the collective outcome. So we need to do 2 things. The one is to have a collective multidisciplinary, this is the broad package that we would like to be able to provide, or we're going to pay to provide at that level outside of hospital. This is the current available spectrum of practitioners and practices and establishments that is available, and they're either working in a collective and multidisciplinary teams or they are not. And then we need to say, well, if we're going to risk adjust and if we are going to get strategic purchasing in so that we get equity across the service delivery, we need to count what kind of care we are giving to people. So we're doing it for different reasons. At the end of the day, collectively, all of those things add up to what's the outcome. And if the outcome, based on a few measures, because you can't measure every single thing, is that we are seeing less complications of A and B, we're seeing less patients referred for A and D and C, and we're seeing whatever we agreed are the outcomes in that particular cup that need to be addressed, then we are improving the health service. But the total amount of money that's being paid is based on the population, not on how many practitioners there are in the area. And that's going to take time to work out. And as I said, where there are many practitioners in a geographical area, the unit benefit to the practitioners will be less.
Okay, I didn't quite answer my last question, but I'm going to give Shabir a chance to ask the last one. And if there's time, I'll come back to it. Shabir.
Yeah, it's a quick question. Chris, I'm just not clear enough yet about whether there's going to be payment to GPs from the CUP. They will receive by capitation, but will the GP, and I want you to describe the experience of that GP. How is he going to enroll patients and how is he going to get paid on a capitation basis? How will he also then get paid if there's any fee for service, which you didn't mention, and then performance management? Just clarify, and do it like you did. You sitting in the GP's chair, what do you experience?
Okay, so there's nothing in the bill or in any legislation at the moment that says an individual GP will be paid for patients on their books. That's not what it says. It says the CUP will get paid, the capitation. How each person will be paid in there could be a flat rate. It could be a flat rate plus a performance. It could be a flat rate plus a fee for service for add-ons plus performance. So those are the models which various people have put on the table. We have several different models, and we need to experiment with them, first of all, systemically, and then to see whether the patient, remember, we are interested in the patient outcomes. And obviously, if you're chasing all your practitioners away because your model doesn't work, then you've got a bad model. But if you are only focusing on how to pay the practitioner and not how we get the benefit to the patients, then we also haven't achieved. So I'm not going to be able to describe to you letter by letter how it's going to work because we don't have the unit who's going to be running those projects yet. And I'm not going to be held by you or others to Dr. Crisp said. What I said is that there are options and there are models that we need to experiment with, but what we are going, I've put the principles down. So we are far away from the details of here it's going to work like this and there it's going to work like that. We may say to CUPs countrywide, here are your options. You're going to get given 10 million rand in this cup for XYZ period. And these are the practitioners. This is the outcome we're expecting to see in terms of patient outcomes. Everybody must get care. And if you are sending everybody to hospitals to prevent yourselves from having to do the work, the system will pick it up. And if you are unable to deliver the care because there are insufficient practitioners, we need to find a way to get more practitioners interested in coming into your area. So systematically and slowly working that there's better equity in the distribution of resources, including money, people, etc. So Shabir, I know I can't answer your question in stepwise. This is exactly what you're going to get paid because we're not there yet.
Yes, I think this is a very interesting issue that Shabir and you are talking about, because I think also the capitation principle really makes a lot of sense as the foundation, but if that only goes as far as the cup and not as far as the actual establishments and primary care providers, that may change quite fundamentally the incentives and drivers for what actually happens, you know, on the ground. So I mean, and I hear what you're saying. We don't actually know yet how that's going to work, but that's a really crucial piece of the puzzle. Yeah. So everybody, our time is up. I think we may need some more of these conversations next year, Nicholas. But I'll speak to you about that as things unfold and things evolve. Obviously, there will be more detail available. But thank you very much. Thank you very much for the time and for your willingness to engage with the Academy of Family Physicians and the sort of community of general practitioners and medical officers that are here on the call. We will, I think the recording of this will be available on the Academy website at some point. And we will let you know if we have the opportunity for further conversations in the new year. So thank you very much for being here. Thanks.
Thank you all. Thanks, Bob, for organizing. Cheers then.
Thanks.
Bye.
Bye-bye.